Our first respondent is Dr. Christina Puchalski, who many of you know is an international leader in the movement to integrate spirituality into healthcare. She's founder and director of the George Washington Institute for Spirituality and Health at GW in DC, professor of medicine and health sciences at George Washington, and board certified in both internal medicine and palliative care. She's authored numerous articles and book chapters and published a book with Oxford University Press entitled A Time for Listening and Caring, Spirituality in the Care of the Seriously Ill and Dying. And she's also the co-editor of an international textbook on spirituality and healthcare with Oxford. Christina, thank you for coming.
Thank you, and thank you for the excellent presentations. These studies have been very important and in a number of ways. Dr. Balboni, Tracy Balboni's study is one that's been cited frequently as a support for addressing spirituality, religion, and health in medical education, and also for many of the reports, Institute of Medicine, Dying in America, et cetera, and the importance of having an evidence base, a beginning evidence base on this area. And in terms of the clergy project, something you may not have known, but many, many years ago I was involved with RWJ, and there were a lot of clergy-to-clergy initiatives and conferences on trying to get clergy to understand more end-of-life care. And it's clear from your studies that a lot more work has to be done, I think, in how do we educate and work with clergy in this important area. So I've been asked to respond a little bit more about the clinical applications of this and perhaps a little bit more on education. So just some of the challenges, I think, on the research in this area. In all of our talks today, we've had the R sort of / religion and spirituality lumped together, but that there is still a big debate around spirituality versus spirituality and religion. And I think in some ways religion is easier to define and measure in some aspects, but in terms of spirituality, the definitions are diverse, multifaceted, and not always that easy for research methodology. There are very good measures, Ken Pargamitz and others, on religious coping, but not many measures on spirituality, on spiritual distress. So I think in terms of some future areas on research, just looking at some of the clinical aspects of spiritual care, we talked a little bit about this at lunch in terms of what chaplains do and what some of the rest of us do. It's important to look at some of these areas as we build evidence on the role of spirituality and religion in health. I will say this notion of diagnosing spiritual distress, and particularly around end of life, there's a lot of studies that show spiritual distress is very high, and yet we don't really have good clinical measures or even research measures on spiritual distress. There's a group in India that's now working on a scale that I think is very interesting because it incorporates spirituality broadly defined, religious culture, values, beliefs, and practices as well. And then the NCCN Comprehensive Distress Management Guidelines do have distress guidelines, some of which are for spiritual distress, some of which are evidence-based, a lot which are not. So that's just my comment sort of on a reflection of the day in terms of the research. So the definitions around spirituality have been developed by some consensus conference. The European Association of Palliative Care developed a related one, and then there's been a global definition around spiritual care. And you will see that it's a very broad definition, dynamic, intrinsic aspect of humanity through which people seek ultimate meaning, which we talked about earlier, purpose and transcendence, and experience relationship to self, family, others, community, society, nature, and the significant or sacred. And then that group felt it was very important to add to this definition that spirituality is expressed through beliefs, values, traditions, and practices. So the table in the back that was composed of the researchers stood up and said, no, we can't have a definition like this because it's not easy to study in research. So I think this is a huge challenge of how do we incorporate broader understandings of spirituality in research studies. I've mentioned this, many people have mentioned this today, that there is more recognition of spirituality as part of clinical care. It used to be something outside of clinical care, and we're moving more into it. And these two studies actually really support that people's religious beliefs can impact their choices around end-of-life care and other choices as well, not just end-of-life care. And that clergy who might work with congregants might have belief systems that maybe might skew patients' understanding or what they might feel that they're comfortable with. And so really educating both clinicians and clergy in this is really important. We also know that spiritual and existential distress can impact quality of life, pain management, and since quality of life is recognized as being so important, spiritual well-being is therefore a huge part of that, and spiritual well-being is a domain of quality of life. And Betty Farrell and her group have done a very important intervention study that have shown that even a small exposure to education around spiritual well-being can impact depression, anxiety, and of course, spiritual well-being in patients and family caregivers of those who have advanced cancer. So looking at the WHO resolution, you'll see that, in fact, there is, in terms of the definition, people have used these definitions for providing spiritual care as part of palliative care. It's an approach to care that improves the quality of life of patients through the prevention and relief of suffering by means of early identification and correct assessment and treatment of pain and other problems, whether physical, psychosocial, or spiritual. I will tell you that it was a struggle getting the word spiritual in, and we're happy that it came in there, but there is still a lot of conflict at policy levels in addressing that. So what is the role of the rest of us in the team in addressing and providing spiritual care? And Tracy mentioned spiritual care provided by the team. Well, as I mentioned earlier, there is a generalist specialist model, but we all are responsible for doing it. Board-certified chaplains should be part of the team. Clergy, shamans, and other types of providers are often considered as non-healthcare team members, but do, as we've seen from Michael's study, are involved in the patient's circle of support. And access of clergy sometimes is hard in a hospital setting, but they should be considered as interacting and impacting patients' decision-making. And as we move to community settings more for healthcare settings, clergy and other culturally based healers may certainly be involved in that. And we haven't mentioned faith community nurses, but they are a key piece of care in the community. So WHO also talked about how it's an ethical responsibility of all of us in health systems to alleviate pain and suffering, whether physical, psychosocial, or spiritual, and the resolution also acknowledges the importance of professional spiritual care providers. So again, we have backing to do that in these settings. Now, I was interested in this whole opening to choosing around what people choose for aggressive care versus not, data on treatment preferences. And so some of this comes from a lot from my own clinical experience. I'm often called both from an ethics perspective, but also in palliative care, to get involved in these difficult conversations where teams think family members or patients should move in a certain way and they don't. So I think that the focus only on particular religious beliefs sometimes can, and if it stops there, can cause a war. This family believes in miracles. We're never going to get a DNR. This is a problem. Looking at religion is a problem, but these are deeply held values, and we don't want to get into those kinds of war situations. So sometimes I think for us to move beyond just the religious belief to maybe the intrinsic religious or spiritual aspects might actually help us approach these questions better clinically. Like, what matters in your life, or what do you think would matter in your father's life at this point, if it's the parent that's in the intensive care unit? Your faith sounds very important to me. Tell me more about how this helps you with what you're going through. With what's the meaning in this situation? Maybe exploring hope within a religious context or a non-religious context. So aligning with the patient, not fighting with them about their beliefs or not against our scientific beliefs, but rather moving to another realm of conversation, which I think moves into a deeper spiritual realm. So we move away from that clinical war that often occurs between religion and science. I can't tell you how many times I'm consulted because the team is upset that a certain clergy member or a patient wants a certain belief. How can I undo it? It's not up to me to undo that. So I think that's really key. And I think the other is, we often on healthcare teams want to have a goal at arriving at a hospice referral or a DNR decision, but I don't think that should be the goal. The goal should be presence to the family and the patient at that time and trying to arrive at a goal that's consistent with their beliefs, even though it might conflict with what the medical team wants to do. So I actually have patients who are not that religious, but they know I'm not going to push them to a DNR. So they feel free telling me this. Patients who are not that religious, but will say they are because they want to push the palliative care team or the ICU team away by saying, this is my religious belief, I'm not talking about it, I'm a full code. But that's not really where they are. If you explore it more, it's trust in the health system. It's having had a bad experience, being afraid that that DNR means do not treat. And so there are many other factors, and I think it's important clinically and in research that we should explore those as well. I think the implications of these studies are very, very important. You know, we do have to think about who's going to do that. I'm going to show a case a little bit about that. I think, you know, looking again at our role. So let me do a case that we have to actually talk about with our medical students a lot. And this is a classic patient, 72, COPD, advanced chronic obstructive pulmonary disease, on a vent for 2 months. She has very bad lung condition, multi-system organ failure. Her doctors say she may only have 1% chance of being extubated successfully and probably not living beyond that. They have discussions with the family, and she has advanced directives, but indicates her husband should be her surrogate, and he and his 2 children insist that ventilation should continue. So this is a multiple choice answer from our questions that Betty Farrell does when she teaches similar things. What should we, clinicians, non-chaplains, non-clergy, do? Tell them that belief in miracles is delusional and call for a psychiatry consult. Review the statistics about survival and that miracles won't happen for people like this. Explain to the family that their beliefs in miracles is causing her great harm. Convince the family that if there will be a miracle, God can perform that miracle without machines. Or convene a family meeting. Now, I bolded that because that's obviously the right answer here. But I wanted to put those, and I actually added that one, because I hear this a lot. And I think Dan said this at lunchtime too. It is really critical that we look at what is our role on the team. I think it is really dangerous for the physicians and the nurses to start looking into belief systems and manipulating them around so that we get what we want or recommend medically. And this is where I think it is really critical to work with board-certified chaplains in these arenas, because board-certified chaplains have this kind of training. They do not have an agenda, a medical agenda. We do, or we're perceived of as having that. And so I think that's a really big part of how we can work together as a team. I can say, I can align myself with the family and acknowledge that their faith is important and this belief is important. I can share with us what our scientific belief system says. But to have a clergy as part of that conference, a chaplain as part of that conference, I think is really, really important. I will tell you something I'm seeing around the country. Several chaplains have told me this, that chaplains on palliative care teams sometimes feel pressure from the team to help make that patient a DNR. So some of the chaplains said, okay, I can hear that. So that's not a good idea either. I mean, chaplains need to support the family's wishes or the patient's wishes as well. So it's a complicated conversation, but I'm just going to raise it as something. We've already talked about this, but we do teach this around the country: presence, communication strategies, finding common ground, exploring hope. Really also recognizing that religious statements are, it may not be, the miracle may be coming from another source, a denial about the illness, they may be rooted in fear, there may be other reasons. And so people with training around theology, namely chaplains, can help unravel some of that. There's a protocol called the Amen Protocol that was developed by Rhonda Cooper at Johns Hopkins as a good way for the non-chaplain clinicians to be thinking about how to address this. I've already said this, but I think referral to CPE chaplains is critical. They can help us discriminate positive, negative coping, help clarify patient misunderstanding of their doctrine if that's the case. They might be able to help reframe miracle. I don't think it's important for us to do that, and they don't have a medical agenda. I finally just want to say a little bit about training. I think education and training should be across the continuum in all of our professions. Clinical aspects are important for us as clinicians to know. Competencies and standards should be integrated into standard curriculum, not just standalone elective courses. Chaplains integrated into medical school and nursing education, which they do. And in terms of clergy training, in seminaries, is one unit of CPE enough? I'm not sure. But I think there should be more training about their role within medical environments as well. And just to show you an example, in our school, and it's taken a long time, so you have to be patient. This was 1992 that we started the course is that it's taken a long time to make it required. It is integrated into different segments, so it's not a standalone course, but it's seen as part of whole patient care. And I will say that the last bullet, the overall four-year curriculum goals now at GW do have specific, explicit issues around spiritual concerns and spiritual care in 3 of the overall goals. That has taken about 12 years to occur. So it does take time within your organization, but I think it's possible to start beginning to change curriculum a little bit at a time. So thank you for your attention, and we'll look forward to more conversation.